Hey everybody, what's going on? Today we're going to be talking about exercise prescription for health and fitness. Realistically, this slide deck, this presentation, this lecture, whatever you want to call it, is going to be a little bit shorter. It's going to be a little bit more concise, and really it's a little bit more text heavy on the slides. But the reason that I wanted to still talk about the subject is I want to give you basically like a prequel for what you can expect in exercise testing and prescription with Mrs. Alvarez. What realistically is going to be coming into this is kind of like throwing a tangential line, attaching a lot of it to what we've already talked about, but also trying to just really see what the recommendations are like for exercise, right? Like we can talk about exercise physiology so much, but we also need to talk about what are the recommendations for exercise. So a couple of key terms that we need to make sure that we're paying attention to is physical activity, physical fitness, and exercise. Realistically, physical activity is basically any form of repetitive muscular activity involving large muscle groups. Think going about a daily walk, walking from class, that type of stuff. Physical fitness is then going to be a specific set of attributes, right? Straight up Liam Neeson, a set of attributes that people have or develop related to ability to complete said physical activity. So the better you get at physical activity, the more improved your physical fitness is. When you start beginning to plan exercise and beginning to plan physical activity and beginning to set up workout programs, that's when we get a shift from physical activity towards exercise. And it's almost like a level of seriousness with which you're taking it. When it becomes dedicated and planned activities, it becomes exercise. If it's just a daily spur of the moment thing, it's physical activity. What we need to begin, and really what we have been thinking about for, I think it's since like 1996 is when the exercise is medicine program came out. Essentially what we're doing with exercise is prescribing exercise, right? Exercise is a miracle drug, if you will. If there was a drug, if there was a supplement, if there was a dose of something that a physician could give to a patient to get the same effects as exercise, it would be earth-shattering, right? There is nothing on this planet quite like exercise when it comes to its ability to affect change. And that has to do with a lot of our body's natural responses to the environment and how we respond to homeostasis, like deviations in homeostasis, how we get back to homeostasis and how our body adapts. Just like physicians prescribe doses of drugs, we need to learn how to prescribe doses of exercise. And when we learn how to prescribe doses of exercise, we need to know what dose is equal to what response. What is the dose response effect, right? If I give you 30 minutes of exercise a day, how much of an effect is that going to have on heart rate, on blood pressure, on ventilation, on asthma, on all those things? So think about it like this. What is the minimum level of activity that you can do, or what is the minimum dose that you can do to get the maximum therapeutic effect? And that's what we're talking about when we're talking about dose response. What is the X dose for Y response? When we're looking at a dose response curve, whether it's for exercise, whether it's for drugs, whatever, what we're really basically doing is we're dividing this dose response curve into a couple different sections. One, we're going to have the potency, or that is the ability to make a difference. So if we're on a steeper portion, then we're going to be talking, if we're on a greater slope or a steeper portion, we're going to be talking about the potency or the ability to make a difference. If it's a flat level, it's not really going to be eliciting a difference. But if we're increasing or decreasing, if we're on the curve aspect, then it's actually going to have some level of potency, whether positive or negative. That slope, so the slope or the change in y per unit of x, the change in y variable per unit of x, is basically going to demonstrate how efficacious a dose change is. So for every increase in dose, what response are we getting out? The maximal effect is basically going to be how high of a level can we exert, how much of a benefit can we gain, right? So something like strenuous exercise can significantly improve VO2 max and reduce risk factors, but low intensity exercise can also reduce risk factors, yet have a minimal effect on VO2 max. So if we're looking for an individual that's just trying to get healthy, do they have to necessarily work at a very strenuous work rate or very strenuous intensity? Probably not. They might be able to elicit a maximum effect on health without having to go through a period of suffering, if you will, or going through high levels of strenuous activity. Then there's also going to be a level of variability. So there's going to be interpersonal differences. So what works for me might be different from what works for you. It might be different from what works for your participants or for your patients or for your clients. So you need to understand that these dose response curves are individualized. We can begin to create a mean or an average based on experience and based on what we see in the research. But in general, it's going to be very variable. See what I did there? It's going to be varied based on the individual. And then the other thing is going to be side effects. So if we get all of these positive benefits, if we get improvements in VO2, improvements in blood pressure, improvement in heart rate, what is the potential downside of the drug, of the exercise routine, of the exercise program? Well, when it comes to drugs, there's usually expected on-target and off-target effects. So if we block insulin receptor, we might expect to see changes in glucose as a side effect. When we exercise, we're putting our body out of homeostasis, so we'd expect there to be some level of side effect. Realistically, when it comes to exercise, there's not a smattering of side effects like there is with drugs. The main side effect that we're going to have is usually injury. So how is it that we get a specific dose of exercise? Well, we're going to use the FIT principle, which is frequency, intensity, time, and type of exercise. So we're going to be talking about progression, we're going to be talking about overload, and we're going to be talking about specificity. We can use these different things to essentially also calculate something called volume. And what our volume is going to be equal to for our endurance training is our number of days or our frequency of exercise along with our time of exercise. So if you run for an hour every day, your total volume of exercise would be 7 hours. Whereas resistance training, it doesn't quite work like that because you're not consistently lifting weights the entire time you're in the gym, right? Like you're going to be sitting there broing out, sitting at the water fountain, sipping on your gains. But with resistance training, how we calculate volume is going to be multiplying the load, so the weight times the number of sets times the number of reps. And that's how we're going to calculate volume for resistance training. Now, how we progress through that, how we apply the principles of progression and apply the principle of overload is how we're going to manipulate the dose of exercise for both endurance training as well as for resistance training. When we're dealing with the physical activity dose, when we're dealing with the side effects, or we're dealing with what is the optimal dose to be prescribing to someone, it's really predominantly going to be dependent on the goal or the health or the fitness outcome. If someone wants to be able to run a marathon without stopping, they're going to have to do a higher level of physical activity. Like that's going to be a physical fitness goal. However, if you have someone that is trying to decrease their blood pressure or improve their endurance so that they can keep up with their grandchildren, that's going to be a little bit different of a level or a volume or an intensity of training. So what we really need to almost think about is physical activity and health and dose of exercise almost having a U-shaped curve, so that on the y-axis we have a change in health problems. As we decrease, as we go down in the y, as we go down vertically, we're going to actually improve health. As we go up vertically, we're going to make health or side effects more prolific or more pronounced. And then on that x-axis, it's for every unit of increase in volume or increase in time or increase in duration or whatever, increase in dose, if you will. So at the onset, realistically, you can see that some of the biggest doses of the biggest dose responses, the best benefit comes on the left-hand side of that figure. So that as you transition towards increasing physical activity, you're going to actually get significant health benefits. But once you transition over into that physical fitness or sport realm, it actually becomes that dose might be a little bit too much. You put yourself at increased risk of injury, increased risk of skeletal muscular injuries, increased risk of overuse injuries. All those things start to kind of creep up. So there is a certain level of dose response that is associated with low side effects and with high side effects at the same time. So what about some of the dose responses of some of the primary health variables that we're going to be looking at, right? Insulin sensitivity, blood pressure, VO2 max, heart rate, HDL, the good cholesterol, happy, high density, low lipoprotein. Each one of these are really, you're going to have to look at the different response patterns. An acute response is going to be essentially instantaneously. So after one or really just a few exercise bouts, you'll start to see dramatic improvement in the response. So something that you can see is like blood pressure. You're going to actually see pretty significant improvements in blood pressure rather early. You can also have rapid benefits, so that it's an early benefit but with an eventual plateau. You can have linear, so you can actually have essentially gradually increases in improvement, something like a VO2 max where you can gradually increase, or you can have delayed, so you can have virtually no effect for a while and then all of a sudden you start to see an effect. So it's weeks later. So something like hypertrophy and resistance training would be a delayed response. Significant improvements in HDL or happy or high density lipoprotein or the good cholesterol is going to actually be a delayed pattern. It'll take a while for it to occur, but once it does, it increases pretty dramatically. So if exercise is so good, why is it that so many Americans are so out of shape and so unfit? Well, we can talk forever on this topic, but what we do know is that essentially in 1995, 1996, the ACSM, American College of Sports Medicine, and the Centers for Disease Control, or CDC, basically published a landmark study, or really landmarked guidelines. And this was really the initiation of the integration of exercise as medicine, or the improvement of health based on exercise and nutrition. So really trying to use exercise and nutrition as a drug, which is something that historically we have done. If you look at ancient Roman times, if you look at ancient Greek times, if you look at really any ancient civilization, they basically celebrated health and fitness, whereas nowadays we're not really doing that. So 1995, Landmark's activity guidelines come out. While they've changed some across time, realistically what it comes down to is that we want to be striving for physical activity volume of about 30 minutes or more of moderate intensity physical activity daily. Now you can get away with most days out of the week, but the goal is going to be 5 to 7 days. You can go lower, but ideally you want to be working out most days of the week. You can achieve this with about 150 minutes per week of moderate physical activity or 75 minutes per week of vigorous physical activity. Those activity volumes are going to be dependent on the intensity level. So the higher the intensity, the less MET minutes, the less physical activity minutes that you're going to actually need. They almost count more, right? Like they're worth more points, if you will. Those MET minutes, or those physical activity minutes, can actually be broken into smaller time chunks. And realistically, we can break those down into about 10-minute chunks. So if we want to be working out for a minimum of 30 minutes every single day, it's 3 10-minute chunks, or 3 10-minute chunks of physical activity, not necessarily working out. And those 3 10-minute chunks is enough to achieve significant improvements in health and well-being. So that's great. We want to be able to hit that 75 to 150 minutes minimum per week for vigorous, moderate intensity exercise. How is it that you prescribe to achieve that dose, or to achieve that essentially dose response, if you will? Well, if we were to just go on subjective feelings, just go on how hard do you think you're working for vigorous versus low versus moderate intensity, you'd probably learn pretty quick that people have a tendency to overestimate how hard they're working, whether it's how hard they're studying or how hard they're actually physically being active. So we need a way to come up with an equivalency. We need a way to actually quantitate this difference. So what has been done is there's a concept called metabolic equivalence, or METs, METs. And now what a MET is it's basically a unit of measure for intensity. So at rest, pure rest, like what I'm doing right now, what you guys are doing as you're sitting here listening to this lecture, is about 1 MET. And that 1 MET is equal to 3.5 mLs per kg per minute. 3.5 milliliters per kg per minute is equal to 1 MET. So you should see that ml per kg per minute and know off of our last week's lecture for endurance training that that's going to be a relative VO2 because it's using kilograms per minute and it's not liters per minute. So essentially for every increase of relative VO2 that you go up of 3.5 mLs per kg per minute, you're going up 1 MET. So rest is 1 MET. That's our baseline. That's our anchor. As you increase in activity, say you're transitioning from low exercise rest to vacuuming the stairs, you're going to actually increase to probably a moderate level. So your VO2 will increase about 3 times that. So that's a way that we can actually describe intensity of physical activity. If we anchor with 1 MET is rest, you're sitting in a chair, we can actually prescribe, I want you to be working 1 time harder than you're sitting in a chair, 2 times, 3 times, 5 times, 10 times. I want you to be working as hard as you possibly can, right? Like we can adjust based on METs, how hard an individual is working, the intensity of the level of exercise. Well, where we start to begin to see physical activity benefits in health are going to be about 3 METs. But we get even further increased benefits when we get to 6 METs and above. So as we move into that moderate vigorous intensity exercise, we actually start to see more benefits. So just like you can reduce the dose, you can reduce the number of minutes, the volume, you can also get better benefits by working at a higher intensity. So how do we then take this concept of intensity and combine it with volume to actually start prescribing this? What we're going to do is we're going to create something called a MET minute. And what a MET minute does is it takes and multiplies the METs that you're working out at times the volume, or the number of sessions times the length of that session times the duration of that segment of exercise. So let's say you're walking 2 days a week at 5 METs, 5 times harder than rest, 5 times harder than sitting in a chair. And each one of those sessions lasts about 30 minutes. Well, you take 2 times 5 is 10 times 30 equals about 300 MET minutes per week. So you can actually take and calculate out how many MET minutes per week an individual is achieving. The ideal is that we're going to be achieving about 500 MET minutes on the low end. You get better benefits and more benefits health-wise as you go above 1,000 MET minutes per week. So our goal should be to try to achieve 500 MET minutes per week when we're working with someone as we're beginning to prescribe exercise. We want to work them up, progress them up, overload them up to 500 minutes per week. Once we get there, we can start trying to taper up and up and up to get closer to that 1,000 MET minutes per week. Now, at this point, I'm sure most of you guys have an Apple Watch, or you have your iPhone, or you've got some sort of Garmin or pedometer-based tracking, whether it's your phone, whatever it is. You'll know that you're getting step counts or pedometry. And those step counts are essentially representative of light intensity physical activity or light intensity exercise, or low MET 1 to 2.9, 1 to 3 MET activity. Realistically, it's just going to be background physical activity or spontaneous physical activity, standing up and walking across campus to go get a cup of coffee. That's going to be light intensity background physical activity. We can actually use that cadence. We can see how many steps you're going to be achieving in a specific time or in a specific day to estimate about how hard you're working or what your physical activity level is, whether it's light or moderate vigorous. And that threshold is about 7,000 to 10,000. So we can consider 7,000 or less steps light physical activity. As you move north of 10,000 becomes moderate vigorous physical activity. So that's why kind of the people say to walk 10,000 steps a day. What we're trying to do is get increased benefit, increased health benefit, and improve our MET minutes per week, and thus improve our health. All right, on the next video, we're going to continue on with this lecture.